Welcome to Dateline Health. This is Fred Lippman coming to you from the Alan B. Levan Innovation Center at Nova Southeastern University, which is a combined effort between Nova Southeastern University and Broward County Commission, actually. We have a wonderful guest today because, as you know, those of you who have been watching us for these many, many years, the questions really come from the viewers. And we have a great number of thoughts and interest in the issue of basically cancer, but specifically breast cancer. And so I've turned to try to find a specialist and someone who's dedicated to breast cancer screenings and treatments. And right on the screen right now is Dr. Jessica L. Burgers, who's a specialist in breast surgical oncology, and she is at the Holy Cross Hospital in the F.A.C.S Center. So welcome, Dr. Burgers.
Thank you for having me.
So tell us now, tell us about the F.A.C.S Center at Holy Cross Hospital.
So the F.A.C.S Comprehensive Cancer Center is, as the name describes, comprehensive. I am part of the surgical oncology department here, focusing in breast cancer surgery. I also do have a focus in benign breast conditions as well. But within the same facility, we have radiation oncology as well as medical oncology. And to support all of the physician teams, we also have dedicated dietitian, dedicated physical therapists, as well as social workers to, again, round out the care of the cancer patient. Treating a patient with cancer is not just a one physician effort. It takes the whole team coming together to collaborate and provide individualized care for each person.
Well, you know, today with the way healthcare is provided, there is a great demand for cooperative care.
Correct. And, that's the beauty of how we've come to understand medicine is that our best outcomes happen when we are collaborating together. All of the specialties that you've just described, we have some insight into what the other specialties do because we interact so regularly. At the F.A.C.S Center, our breast program is kind of our star program where on a specific morning, on Wednesday mornings, we have patients come and get to meet with the whole team of providers that I just described. After they meet with the providers, then we sit down and have what is known as a tumor board or a tumor conference, where we review the cases, we review the imaging with the radiologist, the actual pathology slides. And in doing that, we can really provide our patients with the best, most up-to-date care, thinking about each case again as an individual. Because of this collaboration, we're actually recognized by the National Accreditation Program for Breast Centers, abbreviated the NAPBC. And I'm happy to report that just this past month, we got our reaccreditation. And so, not only are we providing great care, we have been recognized by this national organization as following the ultimate standard of breast care.
Let's talk about the screening issues and self-screening, palpation, things of that nature. Let's let the people out there know what you would expect your community at large and your patients should be doing.
Right. So screening mammography, there are a lot of different organizations that put out recommendations about how we should approach screening mammography as well as self-breast exam. There was a lot of press recently in May when the U.S. Preventative Task Force kind of modified their guidelines to say that screening mammography should begin at age 40. This is interesting because a lot of other organizations, like the organization I belong to, specifically the American Society of Breast Surgeons, as well as the American College of Gynecology, they were recommending initiating screening at 40 for many years. But the USPTF kind of came in line with these other guidelines. I think the thing that guidelines are trying to address is population health. So trying to do the most good for the largest number of people. And by doing the most good, we're trying to detect cancer early. But these organizations are also trying to weigh, the potential harms of screening, which might be the cost of a test or the need for additional images. And so they're trying to balance all of these different entities and making the recommendations. But the thing I like to emphasize is that, all those either population-based recommendations, patients are individuals. I'm going back to the same theme that each person comes into a physician's office with a different level of risk for breast cancer within their life, whether that's because of their family history, because of things related to their hormonal history. And then, they also come with different motivations to screening, different anxieties and thoughts about screening. And so what I recommend is that patients typically between the ages of 25 and 35, but it's okay if they're older, to undergo a formalized risk assessment. A risk assessment is to try to gauge what an individual patient's lifetime risk of breast cancer is, so we can tailor screening recommendations in that way. Without that sort of formalized risk assessment, I would say women should be beginning their screening at 40, which, like I said, is sort of across many guidelines now and has kind of become a more uniform recommendation. The thing that gets a little more nebulous is whether or not, patients should be going annually, which as a breast cancer surgeon, I feel strongly that annually is our best way to detect cancers early and minimize poor outcomes from the cancer. But some organizations do recommend doing it every other year. But as I said, I think if you have a person such as a gynecologist, a breast specialist, a nurse practitioner who can, as I said, formally assess a patient's risk, then that can help guide us in a way that is best individualized and can achieve what we call shared decision making related to these tests.
With reference to the issues that you just spoke about having after the age of 40, the hormonal entities or the hormonal levels were no longer being adjusted correctly. And does that end up creating a real problem relative to, in this discussion, the breast issues and the breast cancer issues?
Correct. And there, with many things in medicine, at one point, such things like hormone replacement, we thought everybody should be on hormone replacement. This is great. And then we realized, wait, there were some increased risk of breast cancer. And then all of a sudden it became, oh, nobody should be receiving hormone replacement. But as I said, like most things, or as I intend to say, that most things in medicine sort of fall in this gray zone where there are probably some benefits to hormone replacement in specific women. There are some risks. And again, that's where this idea of having a formalized risk assessment for breast cancer can help inform the decision about whether a patient should be on hormone replacement, how long they should be on it, or are they maybe a patient that has an elevated risk for breast cancer where their other options should be selected. When I'm talking about a formalized risk assessment, there are things that exist that are called risk models. And these risk models account for a variety of different things, like the use of hormone replacement. They also can account for family history, how many relatives within a family have had breast cancer and how related those relatives are to the person that is of interest, as well as if patients have had any biopsies that maybe show precancerous lesions. And by putting that into a software model, we're able to predict what someone's 5, 10, and lifetime risk of breast cancer is. And so from there, we can decide if someone maybe should start screening earlier than 40, or maybe if someone is over 40, they may qualify for supplemental screening, such as in addition to mammography, we might think about utilizing MRIs in addition.
There are some people who have to travel 60, 70, 80 miles to get certain types of care or certain types of screening. Do you find that to be, of course in Broward County and in our region in South Florida, the Tri-County area, that's not a present thing. to some extent. Do you find that to be a real problem with your colleagues around the nation?
I think it definitely is a challenge that, we're constantly, trying to overcome. There are ways to try to get mammography units and things out to patients in more rural communities. Earlier you mentioned about, if a patient is feeling something and how do they get into the doctor. One thing that Holy Cross now offers is that patients can schedule their own screening mammography. Screening mammography is mammography done outside of symptoms, but through this channel, if a patient has a concern, it should allow them to get access to having breast imaging and access to a primary care doctor so that we can expedite working up the new problem. While this is something we offer in our community, I mean, you do make a good point about, like I said, these rural communities. There are programs that have mobile mammogram units that go out. But yeah, access is another big hurdle to achieving health equity. One of the things we also have at Holy Cross Health, and I think you did an interview with Kim Saswick, is that we have a program called Partners in Breast Health, which is another way to try to reach underserved patients who don't have insurance, to get them in for screening imaging. And if anything is identified, then they get referred to our cancer center for treatment. During the month of October, our Women's Center does promotions as well for mammograms, where the cost of the imaging and the read from the radiologist is $100 for the whole package. But I know other centers do similar promotions during the time of October and even sometimes into November, December, again, to try to improve access and get patients the imaging so that we can detect breast cancer before it's something that's a lump, a mass that might be more advanced.
With reference to that, what are the surgical options today that's available to the patient?
So the traditional thinking about breast cancer surgery is that either we can do a mastectomy where we remove the entirety of the breast tissue, or a lumpectomy or they use the term partial mastectomy, where we're only removing a portion of the breast tissue that contains the tumor with a margin or a rim of normal tissue around the tumor. We're in a great time of understanding of breast cancer, and a lot of breast cancer treatment relates to the biology of the tumors, where we can really do a lot in terms of trying to save women's breasts, and women may not always be obligated toward a mastectomy. There was a recent trial that was published showing that even patients with multiple areas of breast cancer within the breast could even undergo multiple lumpectomies, again, sort of pushing the envelope of how we're able to, like I said, save breasts instead of removing the entirety of a breast. One of my personal passions is a technique we call oncoplastic surgery, onco being cancer, plastic being plastic surgery, and trying to combine the elements of both of those in order to use plastic surgery techniques that once we remove the tumor, we're able to reshape the breast so that it looks normal, natural, and more aesthetic. When it comes to mastectomies, we're also, sometimes mastectomy is a better option for a patient if their tumor is very large, or sometimes in patients who have a genetic predisposition toward breast cancer, that may be a better option. And similarly with mastectomies, we've been able to really progress how we end up with our final aesthetic results. That being said, like, we are now able to, in certain cases, save patients' nipples, nipple sparing mastectomies. Another thing is that in a traditional mastectomy and removing all of the breast tissue, breast surgeons end up cutting the little nerves to the skin, and the breast would essentially be numb. But now we're doing new techniques in order to preserve nerves and graft nerves, where women are even able to preserve some of the sensation and the sensuality of the breast tissue, of the breast, once the breast tissue has been removed. So these are all exciting new techniques. And even with reconstruction, a lot of times I get questions about if the mastectomy, is a woman going to be eligible for reconstruction, or when does the reconstruction happen? And the reconstruction process begins at the same time the breast tissue is removed. So with all of these techniques, we're leading to better aesthetic outcomes, which leads to better patient satisfaction, but still excellent cancer control.
You know, I was sitting and listening to you, and I'm really happy that you spoke about this particular issue, because a lot of the questions we get or have gotten relative to this all relate to mastectomies. I mean, I would say 2/3 of them relate to mastectomies. And because, and in fact, somebody wrote in something about, and I don't know whether it's still being used, maybe it's my non-knowledge, is CyberKnife still available for that use?
Not really.
Okay. No, somebody asked the question. I'm just trying to, I don't remember who asked it. But the other issue is the chemotherapy that follows. Want to touch on that?
Yeah, and so chemotherapy, we have a couple different paradigms now. I think the traditional paradigm was the surgeon would go first and cut out the tumor, and then chemotherapy would come after. And now, again, back on this discussion about multidisciplinary team and individualized care, there are some patients that actually benefit from getting chemotherapy as the first step. And by giving chemotherapy as the first step, we can potentially shrink the tumors down, allow for a much less extensive surgery at the time we get to surgery. And by giving chemotherapy up front, sometimes it allows us to then get an assessment of how well a patient's tumor has responded to the treatment. That if patients have what we call complete response, where all the tumor is melted away at the time of surgery, we know those patients are going to do really, really well. But if the patient has a little bit of cancer cells that are left, it opens the opportunity for additional therapies on the back end with a lot of the new medications that have been developed, and very kind of targeted medications to individual features of a specific patient's tumor. And so with this is why, I cannot work kind of alone in a vacuum. And I'm happy that, I have such great access to the medical oncology and radiation oncology physicians here at Holy Cross, because it is a discussion between all of us about what step should go first, what step is going to optimize outcomes, what step is going to lead to the best survival rate and minimal chance for local recurrence.
Well, because I mean, it's a devastating thing to many of the people that have written to us. They lose my femininity, this, how am I going to react? But I'm not, you're the expert. I'm just here to make you aware of the questions that come from our viewers. Let me ask you another thing. When the treatments are designed, I would assume, per the extent of the cancer itself, and are they difficult to deal with? Are they available through normal pharmacy outlets, or do they have to be produced or presented at the hospital?
So traditional chemotherapy or infusion-based chemotherapy is done through the hospital, but now we do have a lot of agents such as immunotherapies or hormonal therapies that some are pill medications that patients will take at home and then get periodic monitoring through lab work and things at the hospital. So it is a mix of all of these options. And again, it really depends. When a patient gets a breast biopsy, we're looking at different features within the tumor to help guide and determine which medication, which chemotherapy, which agents will be best.
We're down to the last 3.5 minutes of this show, and I wanted to get this question in. Do I assume that at the Bienes Cancer Center there's also an opportunity for some counseling of the individuals?
Yes, as I mentioned, we do have a social worker, and with our social worker, he is able to connect patients with counseling services. We have support groups that our patients participate in as well, in order to find the community of patients who have been through similar experiences.
That's great. You mentioned before that you know that a particular physician had done a show with us, but we were sort of the home for Dr. Moomin Swami for a number of shows, because we really were very, we had a lot of questions relative to diabetes and his subspecialty, but also you know, the Zachariah family has been, I've had a number of those folks that have been on the shows too during the years. So I'm very pleased that you joined a great group of people. And again, as I've said to you, I know the Holy Cross Health issues very well, and I'm very pleased that someone such as yourself, with the capabilities, the attitude, which very few people understand. They think that that's not part of the profession, but it is part of the profession. You know that. You know, a good hand on someone else's hand when they're nervous is a heck of a lot better sometimes than some of the medications that they have to swallow. That's just my support, thought. Actually, my first profession before I got into education was pharmacy. I graduated from Columbia University College of Pharmacy, and I was a pharmacist as practicing in the community for 25, 30 years. Anyway, long story short, I want to thank you because this has been a subject that we keep on getting questions on, and I was trying to find the right feeling, and you gave the right feeling to the people who asked the questions. So thank you, Dr. Jessica Burgers. We really appreciate your capabilities, your professional attitude, and to me, it's a blessing. I think you ought to be thanked, and I'll thank on behalf of the people who are viewing this show when it gets on the air. Okay? Thank you very much.
Well, I appreciate it. Thank you for having me. I know there's a lot of topics related to breast cancer, and so I'd be happy to answer more questions in the future. You know, it's Breast Cancer Awareness Month, but breast cancer happens all year long. So as I said, I'm glad to be here and happy to educate our community.
Thank you, Dr. Jessica L. Burgers, MD. You are a specialist in breast surgical oncology, and you work through the Vienna Center at Holy Cross Health. Remember, folks, I always tell you that if you have a problem, don't hide it. Don't try to put it off. You've got to talk to your doctors. It makes it a lot easier for you and your family and your loved ones. So please don't just go into a pharmacy or go into a supermarket and buy something you think is going to take away the pain here or this, that, or dissolve this. It doesn't happen that way. You got to go to your doctors. And remember, this show comes to you through the liking of Nova Southeastern University. If you have any questions, you have any comments, there's a telephone number and an email address right here. And remember, my name is Fred Littman. Until next time, see ya.